Bismillah ar-Rahman ar-Rahim. Good day, everyone. Welcome to this session on membranous nephropathy. I'm Dr. Mahmoud Sheikh, a nephrology consultant and World Kidney Academy instructor. My presentation today is centered around evidence-based recommendations for clinical practice about membranous nephropathy. The backbone of this talk is highly regarded CKG review entitled 10 Tips on Immunosuppression in Primary Membranous Nephropathy. While that article forms the core framework, I have also integrated insights from multiple additional sources, including updated guidelines, recent clinical trials, and expert consensus to ensure a broader and more practical perspective. The goal of this session is not only to summarize what has been published, but also to highlight how these recommendations can be adapted in real-world clinical practice to improve the patient outcomes. Primary membranous nephropathy is the most common cause of nephrotic syndrome in non-diabetic patients. Clinically, it presents with progressive proteinuria and gradual decline in kidney function. We now rely on key disease markers, particularly anti-PLR antibodies and serum albumin levels, to help guide diagnosis and monitoring. A major challenge remains identifying which patients are appropriate candidates for immunosuppression and, importantly, when to start. About 30% of patients achieve spontaneous remission without treatment, yet recurrence after kidney transplantation is seen in about 30 to 50% of cases. Another crucial point is the time lag between immunological response and the clinical response. On average, there is a 10-month gap between a fall in anti-PLR antibody level and the subsequent reduction in proteinuria and the clinical remission by definition. This emphasizes the need for patience in monitoring and careful decision making when tailoring therapy of such patients. This slide summarizes 10 key evidence-based tips for management of membranous nephropathy. First, immunosuppressive therapy should be avoided in patients without nephrotic syndrome, while those with persistent or complicated nephrotic syndrome clearly benefit from treatment. For medium-risk patients, Rituximab alone or in combination with CNI is recommended, whereas for high-risk patients, cyclophosphamide-based regimens remain the standard of care. We should avoid steroid monotherapy or MMF as initial therapy since they are less effective. Importantly, management must also address supportive aspects like preventing infectious complications and tailoring relapse treatment to individual risk and personalizing immunosuppression using response markers such as PLR2 antibodies. And for resistant disease, stepwise escalation strategy is advised, and in transplant patients, monitoring for recurrence and timely intervention is very essential. Together, these 10 tips and principles provide practical roadmap for applying immunosuppressive therapy in a safe, effective, and patient-specific manner. This introductory algorithm provides structured approach to managing membranous nephropathy based on the risk of progression. The first step is to investigate potential systemic association. We need to exclude malignancy first through age-appropriate screening, assess for chronic infections such as Hep B, Hep C, and HIV and syphilis, and rule out autoimmune association by testing for ANA and the others. Detailed drug history and evaluation of systemic disease along with kidney ultrasound and chest imaging are also very essential. Once secondary causes are excluded, risk stratification becomes central, guiding us in tailoring therapy when we are dealing with membranous nephropathy, the primary form. And management of nephrotic syndrome and its complication must be addressed, like edema control, cardiovascular and dyslipidemia risk reduction, prophylaxis for thromboembolism in high-risk patients, and infection prevention through vaccination and prophylaxis. Alongside this, proteinuria control is fundamental, particularly with RAS inhibitors and strict blood pressure control. Finally, immunosuppressive therapies should be reserved for those stratified as high risk, ensuring treatment intensity is proportional to the individual's progression risk. This stepwise framework ensures a comprehensive, safe, and individualized management strategy for patients with primary membranous nephropathy. Before we start these steps, we should highlight a practical point on prophylactic anticoagulation in patients with membranous nephropathy and nephrotic syndrome. The key determinant is serum albumin. If albumin falls below 20 to 25 grams per liter, we recognize a particularly high risk of venous thromboembolism. For those patients, the next step is to estimate what's called arterial thromboembolic risk. If the estimated event rate is low, so no prophylaxis is recommended. If it's high, aspirin to be considered. In patients with very low albumin and high risk of venous events, we also weigh the bleeding risk using GN-specific tools. If the bleeding risk is low, warfarin or low molecular weight heparin can be initiated alongside aspirin, but if bleeding risk is high, full anticoagulation is generally avoided. This approach ensures that prophylaxis is tailored, balancing the competing hazards of thrombosis and bleeding, which is particularly important in nephrotic syndrome where both entities risk coexist. Starting from tip number one, avoid immunosuppressive in patients without nephrotic syndrome. Patients with membranous nephropathy, normal estimate GFR, and non-nephrotic proteinuria generally have good outcomes. These patients are also at lower risk of thromboembolic complications and have lower burden of symptoms like edema. They can be managed with conservative therapy. And patients with membranous normal estimate GFR, non-nephrotic proteinuria generally have serum albumin more than 30 grams per liter. But in patients with membranous normal SMGFR, non-nephrotic proteinuria, and low serum albumin levels, other causes of hypoalbuminemia should be excluded. There are no RCTs comparing outcomes in patients with membranous non-nephrotic proteinuria with and without immunosuppressive therapy. However, clinical experience and data from cohort studies show favorable kidney outcomes in patients with membranous who are persistently non-nephrotic despite absence of immunosuppressive therapies. Immunosuppressive therapy thus adds risk without potential benefits. Progressive disease can be identified by development of nephrotic syndrome or decreasing SMGFR, which will be easily notable during follow-up. The presence of high levels of anti-PLAR antibodies at baseline is associated with higher risk of developing nephrotic syndrome. The slides summarize the clinical criteria we use to assess the risk of progressive loss of kidney function in patients with nephrotic syndromes. Patients at low risk have normal kidney function with proteinuria less than 3.5 grams per gram, or they show more than 50% reduction in proteinuria within 6 months of conservative therapy. And in these cases, we usually just observe. Moderate risk patients still have preserved kidney function, but proteinuria exceeds 3.5 grams with no reduction by 50% after 6 months, yet without any high-risk features. For them, we may choose to wait or consider rituximab or CNI with steroids. The high-risk group includes those with reduced SMGFR below 60 or persistent proteinuria above 8 grams for 6 months, or those with proteinuria over 3.5 grams not responding to therapies, and additional markers such as low serum albumin, high anti-PLAR antibodies, increased urine protein like alpha-1 or beta-2 macroglobulin, or a high selectivity index. Here, immunosuppression without rituximab, with the rituximab, cyclophosphamide plus steroids or CNIs is essentially required. Finally, the very high-risk group consists of patients with life-threatening nephrotic syndrome or rapid deteriorating kidney function. In this situation, aggressive therapy with cyclophosphamide and steroids is crucial. In short, this risk stratification guides us from conservative monitoring in low risk to intensive immunosuppression in very high-risk groups. This slide captures how blur has truly changed the landscape of membranous. On the top left, the diagram shows the typical timeline. Patients may present late because of the insidious onset of disease, but once anti-blur antibodies become detectable, they precede changes in proteinuria by months, making them an earlier and more reliable signal of disease activity. KDIGO 2021 guidelines now formally recognize blur testing as a non-invasive diagnostic tool using ELISA cutoffs of more than 14 or between 2 and 14. While these cutoffs are not yet fully validated, they allow us to reduce the reliance on biopsy in many cases, though biopsy still remains essential when patients fail to respond to initial immunosuppression. For prognosis, anti-blur titers have become critical. Traditionally, we depend on proteinuria alone to guide therapy, but blur allows us to stratify risk earlier and with more precision. For example, studies have shown that levels between 150 to 300 predict progression with a 77% positive predictive value, indicating a need for early immunosuppression. KDIGO now integrate LAR2 antibodies levels into their risk categorization, defining more than 50 as high risk and more than 150 as very high risk. Moving to the therapy, BLAR is also a powerful marker of treatment response. In patients treated with Rituximab, complete antibody depletion was observed in more than 70% of cases, and this depletion correlated strongly with clinical remission, usually by around 10 months. And patients with antibody depletion were far from more likely to achieve remission, while those with persistent or recurrent BLAR2 positivity were at much higher risk of relapse, up to 10 times more likely. Importantly, rise in serum BLAR typically precedes clinical relapse by more than 2 months, giving clinicians a valuable window for early intervention. BLAR2 is not just a diagnostic tool anymore, but a game changer for prognosis, we mentioned, risk stratification, and therapy monitoring. It allows us to move from a reactive approach waiting for proteinuria to a proactive biomarker-driven strategy that improve patients' outcome. This slide shows how a serology-based approach can really change the way we manage membranous. Instead of relying only on a kidney biopsy, we can use BLAR2 and thrombospleen antibodies, which are positive in about 80% of primary cases. These antibodies not only help us to differentiate primary from secondary disease, but they also give us dynamic information over time. If the titers are rising, that usually predicts ongoing nephrotic syndrome and risk of kidney function decline, while falling levels often signal remission. This makes antibodies a kind of real-time biomarker, much more powerful than a single biopsy snapshot. They are also they guide treatment since declining levels show response, while persistent or raising levels suggest we may need to optimize the protocol. Importantly, antibodies rebound after often comes before clinical relapse, including after transplantation, which gives us a chance to act early. Overall, this approach improves diagnostic accuracy, reduce unnecessary biopsies, immunosuppression therapies, and could help us to tailor treatment more precisely for each patient. This slide explains the role of BLAR2 antibodies testing in membranous and when to consider kidney biopsy in a patient with BLAR antibody negative. Then a biopsy should be performed with a staining for the BLAR antigen. This may still uncover antibody-associated membranous nephropathy. For BLAR antibody detection in serum, ELISA is the most commonly used test with a cutoff of 14, while immunofluorescence testing is more sensitive, can detect lower levels. Western blot is rarely available. Once patient is identified as having BLAR and associated membranous, levels should be monitored every 3 to 6 months, or more frequently if the titers are very high or rising. If the antibody disappears on follow-up testing, the patient is considered in remission and no additional therapy is needed. However, if antibody persistent, level and persistent level beyond 3 to 6 months. This indicates ongoing disease activity and therapy should be considered. In short, PILAR testing helps us to decide not only on diagnosis but also on timely and intensify management of ongoing membranous nephropathy or relapsing or resistant cases. This slide summarizes the pros and cons of serology-based diagnosis of pilar positive membranous. On the positive side, pilar antibodies correlate very closely and with clinical disease activity, and modern assays like ELISA have excellent performance with sensitivity around 96% and specificity approaching 100%. Using serology can also spare patients the risks and costs and delay associated with kidney biopsy. However, there are important limitations. We should know these tests are not universally available and occasional false positives have been reported. Serology also cannot replace biopsy entirely because biopsy can uncover concurrent or alternative disease that serology alone would miss, and in some cases biopsy remain more sensitive. In addition, most of validation data for PLAR comes from Caucasian population, so generalizability to other ethnic groups or patients with diabetes or advanced kidney disease is less certain. Going to tip number 2, treat persistent or complicated nephrotic syndrome with immunosuppressive therapy. Many patients with primary membranous and nephrotic syndrome will develop spontaneous remission. There are no RCTs comparing outcomes in patients with membranous and no risk factors for progression with or without immunosuppressive therapy. However, the favorable outcomes in such patients is supported by data from RCTs and cohort studies that included patients with membranous and even at least one risk factor. These studies show a favorable outcomes in many patients with membranous with spontaneous remission occurring in up to 40% or more of patients if no risk factor is present and no complications of nephrotic syndrome are evident. The use of immunosuppressive therapy as risk with little, if any, benefit. Going to tip number 3, use Rituximab or Rituximab plus CNI for medium risk patients. This slide addresses the use of Rituximab either alone or in combination with CNI for medium risk membranous. Medium risk patients are defined, as we mentioned before, by moderate proteinuria in the range of 4 to 8 grams per day, preserving kidney function with SMGFR above 60, and moderate elevated antipilar titers more than 50. In this group, Rituximab offers safer and less toxic alternative to cyclophosphamide-based regimens. Clinical evidence shows that 70 to 80% of patients achieve partial or complete remission with Rituximab, compared to only 30 to 35% with supportive care alone. The landmark mentor trial demonstrated that Rituximab was not only non-inferior to cyclosporine at 12 months, with remission rates around 6%, but also achieved better sustained remission at 24 months, highlighting its durability. A key point for patient counseling is that there is typically lag, as we mentioned before, around 10 months between antibody depletion and clinical improvement in proteinuria, so patients and close monitoring is very crucial. For medium risk membranous, Rituximab is now preferred first-line option, supported by strong trial evidence and key guidelines, offering efficacy with superior safety profile compared to older alkylating or CNI-based regimens. This figure summarizes treatment regimens currently recommended for membranous, starting with CNI. Tacrolimus used at 0.05 to 0.1 milligram per kilogram per day, aiming for trough levels between 3 to 8, while cyclosporine given at 3.5 milligram per kilogram per day with a target trough level of 125 to 225, and both tapered slowly. Moving to Rituximab, can be administered as 2 1-gram doses given within 2 weeks, or alternatively 375 milligram per square meter once weekly for up to 4 weeks. In combination protocols, rituximab may be paired with tacrolimus for 9 to 8 months with a trough target of 3 to 8 and an additional 1 gram rituximab dose before tapering to prevent late relapse. On the cyclophosphamide side, the classic modified Poncelli regimen alternates IV mesalpinizolone 1 gram daily for 3 days at months 1 and 3 and 5, combined with oral prednisone 0.5 milligram per kilogram daily in those same months, and oral cyclophosphamide 2 milligram per kilogram daily in months 2 and 4 and 6. Antibody-guided approach add methylprednisolone pulses plus prednisolone and cyclophosphamide with antibody titers such as antipilar used to decide continuation or not. Combination regimens pair rituximab at 1 gram on day 1 and 15 with cyclophosphamide 2.5 milligram per kilogram for 1 week, then 1.5 milligram per kilogram in weeks 2 till 8, alongside a tapering course of prednisolone starting from 60 milligram per day. This table highlights the most important of these, comparing different treatment regimens for membranous, starting with the MENTOR trial. Rituximab showed sustained efficacy with complete or partial remission in 60% of patients at 12 months, matching cyclosporin early on, but clearly superior by 24 months, where cyclosporin dropped to only 20%, while rituximab maintained 60%. The STARMIN trial provides another landmark comparison where the traditional cyclophosphamide steroid regimen achieved higher remission rates than tacrolimus plus rituximab, 54% versus 58% at 24 months, cementing its role as very effective but more toxic option. The ReCycle study added further insights showing that rituximab combined with low-dose cyclophosphamide and steroids produced outstanding results, with the remission rates reaching 55% at 2 years. Together, these pivotal trials demonstrate that in evolving landscape, rituximab offers a safer long-term option. CNI alone tend to relapse after discontinuation, and cyclophosphamide-based regimens, while highly effective, must be balanced against their toxicity profile. Tip number 4, use cyclophosphamide-based regimens for high-risk patients. When we look at high-risk membranous nephropathy, KDIGO 2021 strongly recommends cyclophosphamide-based regimens in patients with markers of progressive disease, those with very low serum albumin below 2 gram, antipilar antibody titers exceeding 275, or heavy proteinuria above 10 to 12 grams per day. These patients are at greatest risk for developing kidney failure if left untreated. The modified Poncelli regimen, alternating steroids with cyclophosphamides, remains the backbone of therapy in this setting, demonstrating superior long-term renal survival in severe cases. Remission rates reaches 77 to 80% at 1 to 2 years, which is remarkable considering the poor prognosis of untreated high-risk patients. Also, the STARMIN trial highlighted the efficacy of cyclophosphamide, showing remission at relatively low cumulative dose, around 7.5 gram within 3 months. Typically, we aim for a total cumulative dose of not more than 10 gram, balancing efficacy against risk of adverse effects. KDIGO emphasized close surveillance, particularly for cytopenias, infections, gonadal toxicity, because while cyclophosphamide is powerful, its toxicity profile mandates close monitoring. Going to tip number 5, avoid steroids monotherapy or MMF and the others as initial therapy. When initiating therapy for membranous nephropathy, it's essential to avoid steroid monotherapy and MMF as a first-line treatment. The evidence is very clear. Steroids alone are ineffective. They don't provide durable remission, and they expose patients to unnecessary toxicity like diabetes, hypertension, and infections. Similarly, MMF has been tested but consistently demonstrate inferior efficacy compared to standard regimens with high relapse rates and poor renal survival. The KDIGO 2012 guidelines argued against the use of MMF monotherapy in patients with membranous. This still holds and is based on the result of only one RCTs in this study of 36 patients. MMF monotherapy for 12 months didn't increase remission rate, was 37% versus 41. MMF in combination with steroid is more effective. Smaller RCT compared MMF and steroid with either alkylating agents or CMI. In these studies, all with relative follow-up, remission rates were comparable. Study using historical controls and comparing MMF with cyclophosphamide also reported similar remission rates. However, relapse rates within 24 months of follow-up was markedly higher in MMF-treated patients. A more detailed evaluation showed that immunological remissions were less likely to occur with MMF. The dose of MMF could be the most relevant variable. Because studies in lupus have used higher dosage, 3 gram versus 2 gram, and in patients with steroid-sensitive nephrotic syndrome, relapse rate was lower in patients with high drug concentration. That's why KDIGO only recommends 3 validated first-line options: rituximab, CNI, cyclophosphamide in combination protocols, such as the modified Ponticelli. Using non-standard regimens like MMF plus steroids may look appealing, but RCTs show they underperform against established therapies. It may be considered only when standard options are contraindicated or unavailable or failed. Tip number 6, prevent infectious complication. One of the most important aspects of managing membranous under immunosuppressive therapy is not only controlling the disease itself, but also proactively preventing and managing infectious complications. KDIGO guidelines emphasize tailoring antimicrobial prophylaxis to the specific immunosuppressive regimen used. The key message is that infection prevention is not a secondary issue. It is a core part of immunosuppressive management, and when applied consistently, it can significantly reduce morbidity and improve treatment outcomes in membranous nephropathy. When we talk about antimicrobial prophylaxis in patients with membranous, for pneumocystis jirovecii, prophylaxis with trimethoprim sulfamethoxazole is recommended if prednisolone is given a dose of 16 milligram or more per day for over 8 weeks, and should be continued until the dose is tapered below 7.5 milligram daily. Similarly, in patients receiving cyclophosphamide or rituximab, prophylaxis should be strongly contemplated, lasting at least 3 months after last dose of cyclophosphamide and at least 6 months after rituximab. For Mycobacterium TB, latent infection must be ruled out before starting immunosuppression, and if positive, isoniazid for 9 months, rifampicin for 4 months should be prescribed. Hep B required particularly caution before giving rituximab or cyclophosphamide. Sustained viral suppression should be ensured because viral reactivation can be catastrophic under immunosuppression. Finally, in lesions where strongyloids sterocourelis is prevalent, screening and empirical treatment with ivermectin 200 milligram per kilogram for 2 consecutive days or as weekly course is recommended to prevent life-threatening hyperinfection. Tip number 7, personalize immunosuppressive therapies and monitor response markers. When we discuss personalizing immunosuppressive therapy and monitoring in membranous, KDIGO 2021 guidelines place strong emphasis on biomarker-driven approach. Monitoring should be not to be limited to proteinuria alone. We need closely track kidney function, serum albumin, and especially antiplatelet antibody levels, which serve as early sign of immunological activity. KDIGO highlights that a reduction of antiplatelet titers typically precede a fall in proteinuria by average of about 10 months, as we mentioned before, and around 50% reduction in antibody levels often predicts a similar degree of proteinuria improvement later on. This time lag is crucial when counseling patients and planning follow-up. During active disease, monitoring should be frequent, every 1 to 3 months, while on remission, extending to every 3 to 6 months is reasonable. Persistent hypoalbuminemia below 3.5 gram per deciliter is an important red flag, as it significantly increases the risk of relapse. What makes this strategy powerful is that biomarker trends allow us to individualize therapy, whether to escalate, maintain, or safely withdraw an immunosuppressive treatment. KDIGO this time moved from one size fits all strategy to a dynamic biomarker-guided roadmap, ensuring that therapy intensity truly matches the disease activity. This figure shows a dynamic clinical approach that combines antipilar antibody levels with proteinuria to guide decision-making in membranous. On the vertical axis, we stratify risk by antipilar titers, high levels above 150, high or very high risk, where spontaneous remission is unlikely, and immediate immunosuppression therapy with close monitoring is recommended. At the other end, titers below 50 generally indicate low risk, where many patients will enter spontaneous remission with supportive therapy alone. But this serological picture is never complete without the clinical correlate, which is proteinuria. Also, we have on the right axis proteinuria threshold mirror disease activity and prognosis. Proteinuria above 8 grams per day often combine very high antibody titers and identify patients with the greatest risk of progression, demanding early and aggressive intervention. In the moderate zone, with proteinuria between 4 to 8 grams per day, antibody trends become especially important. Rising or persistently high titers suggest the need for immunosuppression, while declining titers allow for conservative management. Finally, proteinuria below 3.5 grams per day, particularly if combined by improving albumin, indicates remission, whether spontaneous or therapy-induced, where continuous supportive therapy and periodic monitoring are very sufficient. The category lines emphasize that proteinuria responds later than serological activity, often lagging by 6 to 12 months. That means falling antipilar antibodies are our early predictor of eventual proteinuria reduction, and persistent high proteinuria despite serological remission shouldn't be mistaken for treatment failure. By aligning antibody kinetics with proteinuria levels, this model gives us real-time compass for therapy initiation, escalation, or even withdrawal. Going to tip number 8, manage resistant disease in a stepwise approach. When we are faced with the resistant membranous case, KDIGO emphasizes stepwise and protocol-driven approach rather than jumping from one drug to another haphazardly. The first step is always to reassess the basics, optimize supportive care, and ensure patients' adherence, because poor compliance or uncontrolled blood pressure can masquerade as resistance. If the patient is truly resistant, the next logical step is to switch the mechanism of immunosuppression. For example, for moving from Rituximab to CNI or from CNI to cyclophosphamide. If monotherapy fails, combination therapy may be considered in selected patients. Importantly, if the disease still doesn't respond, clinicians should step back and reevaluate the diagnosis, sometimes even with a repeat biopsy, to rule out secondary causes or overlapping pathologies. KDIGO highlights that each treatment must be given sufficient time to act, typically 6 to 12 months before escalating to avoid premature switching. Evidence shows that the sequential use of alternative immunosuppression strategies significantly improve remission rates, with cumulative response rates reaching 70 to 80% when the structured stepwise approach is applied. This figure summarizes the current treatment algorithm for membranous based on the initial therapeutic regimen. Patients may start with either rituximab or Ritux combined with CNI or cyclophosphamide-based regimen. The pathway is then guided by clinical response and antipilar antibody titers at defined checkpoints. At 6 months, if immunological remission, complete remission, or even partial remission is achieved, we continue supportive care and monitoring. If remission was not being reached after the first course of rituximab, a second course can be considered, and by 12 months, the response should be reassessed. If remission is still absent, cyclophosphamide regimens may be introduced for patients who begin with cyclophosphamide. Decisions are similarly driven by antibody and clinical response, with ongoing therapy only if remission is demonstrated. By 18 months, those who continue to show resistance despite rituximab or cyclophosphamide are categorized as refractory membranous. In these patients, novel therapeutic options should be considered, including next-generation anti-CD20 antibodies such as obinutuzumab, ofatumumab, and anti-CD38 therapies like daratumumab and felzartamab, or enrollment in clinical trials testing emerging agents. This slide outlines the pathophysiology of rituximab, a refractory membranous, reminding us that resistance to therapy is rarely due to a single mechanism. Several pathways can explain why some patients fail to respond, or one factor is rituximab immunization, where patients develop anti-drug antibodies that neutralize its effect. Another is urinary loss of rituximab through heavy proteinuria, leading to inadequate serum and tissue levels. In addition, rituximab underdosing or altered drug handling can reduce effective exposure, while some B cells actively internalize destroy rituximab in invading depletion. Genetic factors also play a role. Polymorphism in the neonatal efficacy receptor can alter antibody recycling and drug resistance. On top of these immunological and pharmacological mechanisms, the presence of chronic glomerular injury scarring may mean that structural kidney damage has progressed beyond the point where immunosuppression can make meaningful impact. Together, these mechanisms highlight why rituximab is highly effective in many patients, but not universally so. They also underline the need for alternative strategy where uh, optimizing dosing, combining therapies, or exploring novel agents in those with refractory disease may be very beneficial. Going to tip number 9, tailor relapse management based on the risk. Relapse surveillance in membranous is just as critical as initial disease management because relapse is not uncommon and can occur even after a good initial response. KDIGO recommends that once remission is achieved, patients should be followed with regular monitoring of proteinuria, serum albumin, and antipleural antibody titers, and kidney function. Relapse risk is not equal for all patients. Those with partial remission compared to complete remissions, and those with persistent hypoalbuminemia below 3.5 are at significantly higher risk. In fact, studies show that up to 40% of patients may relapse after remission. Antipleural antibody levels are particularly valuable here. They often rise before proteinuria, giving us an early warning signal of impending relapse and an opportunity to intervene before significant renal injury occurs. When relapse does occur, it should be managed using the same risk stratified framework as the initial episode, meaning supportive care alone for low-risk patients and immunosuppressive therapies for higher-risk relapses. The frequency and intensity of follow-up should be always personalized based on patient's risk profile. Going to tip number 10, recognize and treat recurrence post-renal transplant. When we consider membranous in the setting of kidney transplantation, it is important to remember that the underlying disease can recur with recurrence rates reported about 30 to 50% of patients. This highlights the need for routine post-transplant monitoring, including proteinuria, graft function, specifically antipleural antibodies testing, which may act as early warning signal, as we mentioned before. Management should follow a risk-based stratification approach, adjusting surveillance, intensity, and treatment decisions for each patient's profile. In terms of therapy, rituximab has emerged as preferred treatment for recurrent membranous post-transplant, achieving remission in 70 to 80% of cases. which is significantly superior to supportive therapy alone, where remission is seen only in 30 to 35%. This slide highlights the main difference between de novo membranous and recurrent membranous after kidney transplantation. De novo disease occurs in patients whose native kidney failure was due to another cause, and it's relatively rare, seen about 10% of adults and 9% of pediatric recipients. It's typically driven by IgG1 autoantibodies and carries highest risk of antibody-mediated rejection. Because of this, treatment often requires intensifying immunosuppressive medication, or even considering plasma exchange or agents like rituximab or cyclophosphamide may be used for worsening disease. Unfortunately, de novo membranous is associated with worse graft survival. By contrast, recurrent membranous represents the reappearance of disease already diagnosed in the native kidney. It's far more common, occurring in up to 40% of transplant cases, usually characterized by IgG4 autoantibodies. These patients actually carry lower risk of antibody-mediated rejection compared to de novo disease. And sometimes antibodies may disappear altogether under immunosuppressive medications. Rituximab remains the mainstay for disease progression, but the overall prognosis is better, with superior graft survival compared to de novo cases. This study highlights the role of antipleural antibodies as a strong predictor of membranous recurrence after kidney transplantation in a prospective multicenter cohort of 72 patients with membranous either on the waiting list or transplant within 3 months. The cumulative incidence of recurrence was 26% at median follow-up of around 23 months. Retrospective validation study in 65 patients transplanted for more than 3 months confirmed similar finding, with recurrence rate of 28% at a median of 65 months. Importantly, the presence of antipleural antibodies before transplantation increased the risk of recurrence almost up to 6-fold, with a relative risk of 5.9, and recurrence tended to occur early within a median of 5 months after kidney transplant. These findings underscore that screening for antipleural antibodies before transplantation is not just an academic step, it provides a practical tool for risk stratification, patient counseling, and tailoring immunosuppression strategies in this high-risk population. This figure shows an algorithm for assessing recurrence risk of membranous before kidney transplantation and the recommended follow-up afterwards. Before transplant, we should always evaluate the risk of recurrence by checking for significant proteinuria in the native kidney, measuring antipleural antibody titers, and noting whether the disease had rapid progressive course, because these factors predict the higher chance of recurrence after kidney transplantation. Once the patient undergoes kidney transplantation, the first year requires close surveillance. Antipleural antibodies should be measured every 3 months, and proteinuria should be monitored every 1 to 2 months to detect recurrence early. After the first year, if the graft is stable, monitoring can be spaced out, with antipleural checked every 4 to 6 months, proteinuria every 3 months. This gradual tapering of intensity ensures close monitoring while avoiding unnecessary burden. If proteinuria or antibody titer rise, a kidney biopsy should be strongly considered to confirm recurrence and rule out other cause of graft dysfunction. In cases where recurrence is confirmed, rituximab again is recommended as a first-line therapy, particularly when proteinuria exceeds 1 gram per day, since it has demonstrated higher remission rates compared with supportive therapy alone. This key principle emphasized here the risk stratified biomarker-driven surveillance. By integrating antibody titers with clinical markers like proteinuria, we can detect recurrence early and intervene with effective therapies such as rituximab, ultimately protecting long-term graft survivance. Thank you very much for taking the time to watch. I look forward for your feedback, and don't forget to follow us on YouTube for the upcoming lectures. See you soon.